Every year, millions of people past the age of 60 sit across from a doctor and hear the same four words: "We recommend surgery." Most nod, most sign the forms, and most never stop to ask the one question that could change everything that happens next. That question is simple. Is this the right operation for my body right now, given everything else going on inside it? I have spent years reviewing surgical outcomes, reading the research nobody puts on a pamphlet, and talking to families after the fact, and here is the pattern I keep seeing. Age by itself rarely kills a patient on the table. What kills people, or leaves them permanently diminished, is a mismatch between an aggressive procedure and a body that no longer has the reserve to absorb the shock of it. A 30-year-old heart, a 70-year-old heart, and a 90-year-old heart do not respond to trauma the same way, yet for decades, the same surgical playbook got handed to all three. That is finally starting to change, but the change is slow, and most patients are still walking in without the information they need to protect themselves. Before going further, it helps to understand a term doctors use privately far more than they use it with patients: frailty. Frailty is not the same as being old. It is a measurable decline in the body's physical reserve, the cushion that lets a person absorb an illness, an infection, or an operation and still bounce back. Roughly 4 in 10 people over 75 show clinical signs of frailty, and that number climbs sharply past 85. Two patients can be the exact same age and have completely different surgical risk because one has reserve left and the other does not. So the real question a surgical team should be asking is never simply, can this person survive the operation? It is, can this person survive the 6 weeks after the operation? Because that is usually where the danger actually lives. Take open heart surgery as the clearest example. Coronary bypass surgery has saved an enormous number of lives, and for a healthy person in their 60s, it remains one of the most effective treatments in all of medicine. But traditional bypass surgery requires stopping the heart and placing the patient on a machine that takes over circulation for hours. In a frail patient with weakened kidneys or early cognitive decline, that machine puts a strain on nearly every organ system at once, and the complication rates in that population run dramatically higher than in a younger, sturdier patient. What most people are never told is that a less invasive option now exists for many of them. Catheter-based valve procedures can treat certain heart conditions without ever opening the chest or stopping the heart, and recovery from these procedures is often measured in days rather than months. The lesson is not refuse heart surgery. The lesson is to ask directly whether a minimally invasive alternative applies to your specific case, because that single question can change which of two very different recoveries a person ends up living through. Spinal surgery tells a similar story. Nearly everyone past 60 deals with some degree of back pain, and it is tempting to reach for a permanent fix. There are cases where surgery is genuinely urgent, particularly when a spinal nerve is being compressed badly enough to threaten mobility or bladder control. Nobody should hesitate in that situation. But a large share of elective spinal fusions performed on older adults are for chronic, non-urgent pain, and the research on those cases is sobering. Complication rates in complex fusions performed on patients over 65 run far higher than most patients expect, and troublingly, a meaningful portion of that pain returns anyway, sometimes because the vertebrae above and below the fused section start absorbing stress they were never built for. Multiple long-term studies have found that physical therapy combined with targeted injections produces pain relief comparable to major fusion surgery for a lot of degenerative spine cases with a fraction of the risk. That does not mean spinal surgery is wrong. It means it deserves the same scrutiny you would give any decision with permanent consequences. Cancer surgery is the hardest of these conversations, because the instinct the moment someone hears the word cancer is to demand it be removed immediately, no matter the cost. That instinct is completely understandable. But the actual goal of cancer treatment was never simply removing a tumor. It is giving the patient more good years of life, and those are not always the same thing. Some of the most complex cancer operations, procedures that remove large sections of internal organs and take many hours on the table, carry genuine risk of what surgeons quietly call a technical success and a clinical failure. The tumor is gone, and the patient does not survive long enough afterward to benefit from that fact, because the surgery itself was more than a weakened body could recover from. This is far more common in frail elderly patients than most people realize. The conversation worth having with an oncologist is not whether to fight the cancer. It is what the realistic alternatives look like, whether that is radiation, targeted drug therapy, or careful monitoring, and how those options compare to surgery specifically for someone with your age and health profile, not for the average patient in a textbook. Joint replacement sits in a different category because for the right patient, it is one of the most successful and life-changing operations ever developed. People go from barely able to walk to gardening, traveling, and playing with grandchildren. The complication comes when an elective joint replacement gets scheduled for someone carrying multiple serious conditions at once, heart disease, diabetes, and poor circulation among them, without first stabilizing those conditions. Blood clots are the biggest danger in this scenario, since a clot that forms in the leg after surgery can travel to the lungs and become life-threatening. Some hospitals now require a structured preparation period before they will schedule joint replacement in higher-risk, older patients, strengthening the muscles around the joint and optimizing blood pressure and blood sugar beforehand, and the hospitals doing this are seeing meaningfully fewer complications. The real question before an elective joint replacement is never simply whether to have the surgery eventually. It is whether your body is in its best possible condition on the specific day it is scheduled. Then there is the category nobody chooses: emergency abdominal surgery, the kind brought on by a ruptured appendix, a perforated bowel, or sudden internal bleeding. Nobody has time for a calm, unhurried conversation in that moment, which is exactly why the conversation needs to happen before the emergency, not during it. Mortality in emergency abdominal surgery for patients over 75 is among the highest of any category of surgery, not because of surgical skill, but because a body already in crisis is being asked to fight on every front simultaneously, and an older body's inflammatory response can spiral out of control faster than it would in a younger patient. There are two things within a person's control here. The first is refusing to ignore persistent abdominal pain, bloating, or changes in bowel habits, since catching a problem early frequently means treating it before it ever becomes an emergency. The second is having an honest conversation with family now, while everyone is calm, about what quality of life matters most and what you would want if surgery ever became the only option in a crisis. So, what do you actually do with all of this before a surgeon ever mentions your name and an operating room in the same sentence? Ask what happens if you do nothing for the next 6 to 12 months, because if nothing urgent changes, you have time to think and time to get a second opinion. Ask whether a less invasive version of the procedure exists, since robotic, laparoscopic, and catheter-based techniques have expanded enormously in the last 15 years. Ask what recovery genuinely looks like for someone with your specific health profile, not the average patient. And ask the surgeon directly what their own complication rate looks like in patients over 70, because surgeons track this. And a confident surgeon will simply tell you, if you and your doctor do decide surgery is the right path, the weeks beforehand matter more than most people realize. Eating enough protein, walking daily, and if you smoke, stopping even briefly before the date all measurably improve how well your body tolerates the operation and how quickly it recovers afterward. Talk to the anesthesiologist ahead of time, bring a full list of every medication and supplement, and ask whether a regional anesthetic that avoids putting the whole brain under is an option, since it often reduces post-operative confusion in older patients. Arrange help at home before the surgery rather than after, clear tripping hazards, and fill prescriptions in advance, because the first 3 days home set the tone for the entire recovery. Pay attention, too, to how the recommendation itself is delivered. Genuine urgency is rare in elective surgery, so if you feel rushed toward a date with no medical emergency behind it, slow down and ask why. If only one option is ever placed on the table, remember that by this stage of life, there is almost always more than one road, whether that is medication, therapy, injections, or careful monitoring. If a surgeon brushes off hard questions instead of answering them directly, that reaction tells you something important. And if the description of recovery is vague and cheerful rather than specific, that vagueness is often a sign that your feelings are being managed rather than your decision being informed. None of this is an argument against surgery. Surgery saves lives every day, and for the right patient at the right time, it remains one of the most powerful tools in medicine. The point is simpler than that. A surgical recommendation is the beginning of a conversation, not the end of one. You are allowed to ask hard questions, request alternatives, and take the time you need before deciding. The surgeon brings the skill and the scalpel. You bring the final decision, and a decision made with complete information, a clear head, and a second opinion when needed is very often the most powerful outcome of all, long before anyone ever picks up an instrument. As always, this is general information, not a diagnosis or a treatment plan, and any real decision about surgery belongs in an honest conversation with your own doctor, who knows your history and your body better than any video ever could.